Hey, and welcome to the lecture. Before we jump into the learning, just a quick reminder to check out the workbooks available on modernoptician.com through the Ultimate Apprentice Optician Study Guide or available on Amazon worldwide. It's the best way to accompany this lecture so that you can fill in the blanks, label the diagrams, do everything all concurrently, and elevate your training to the next level. All the links to the workbooks and the website are all in the description down below, so make sure to check it out. Other than that, enjoy today's lesson.
All right, so we've been talking about some of the major pathologies that affect the crystalline lens, the cornea, the retina, and there's a number of things that we haven't discussed. So I just thought I'd do a brief lecture on some of the stuff we didn't discuss. Again, we're not pathology experts, or at least we're not expected to be, to do our job effectively. But you know what? I am very much of the mind that the more you know, the better you are. And I want you to understand certain dysfunctions that you will encounter. You won't necessarily be part of the solving of them or the solution. However, again, it all comes down to what I always say. Know normal, and as soon as something's not normal, understand why it isn't so, and understand whether or not it's a problem and whether you need to refer, right? So again, we're gonna, if you take the contact lens course that we offer, we're going to go through some of these in more detail because in those cases, you actually have to decide, as a contact lens fitter, you have to decide whether or not it's appropriate to even fit contact lenses for this patient. This is going to be a little of a precursor for that. This is going to be just a little bit of an introduction to the other pathologies that we may encounter that aren't necessarily linked to the cornea and to the retina and things like that. Some of them might be, but they're not the main ones that I wanted to discuss in detail. All right, so let's jump into a few. Again, I didn't do pictures here because in this particular case, because there's a lecture coming up shortly that's going to go over some pictures, just some quick recognition stuff. But these are the ones I want you to know maybe a little bit more other than just being able to recognize it. So first one we want to talk about is conjunctivitis, pink eye, right? That's a common one. And that's inflammation and redness of the clear tissue covering the eye, the conjunctiva, right? And inside of the eyelid, conjunctiva again, commonly caused by bacterial or viral infections. Remember that the conjunctiva is basically the safety net that covers the eye. It is going to sometimes catch some nasty stuff and it's going to get infected. Bacteria, viruses, whatnot. Common, not a huge issue, right? It's doing its job. If the conjunctiva is inflamed, it means it protected the rest of the ocular structures from that same kind of compromise. So very, very common. There are differences, right? So like there's differences between bacterial infections and viral infections, versus watery discharge versus purulent discharge, but like, mucousy, the level of redness, how far the redness extends, all this kind of stuff. We're not going to get into it. Just know that conjunctivitis is extremely common, not an enormous concern. You don't have to be scared of it. But if the conjunctiva is red and inflamed, probably a good idea to refer, right? Better be safe than sorry. Uveitis. Uveitis is an interesting one. Actually, it looks quite similar at first glance to conjunctivitis, but this is the inflammation of the middle layer of the eye, which includes the iris, the ciliary body, and even the choroid. Now, this is usually caused by infection, trauma, or inflammatory diseases. Uveitis is much more painful, discomforting, and serious than conjunctivitis because this is affecting the inside of the eye. And when these structures get inflamed, there is much more serious implications, both long term and even short term. There's going to have the iris, for example, can become very inflamed and can become fully dilated and uncomfortable. It could start to what's the word I'm looking for? Palpitate, and long-term ramifications can actually cause major widespread infection of the eye, which is absolutely bad news and something that has to be addressed. So again, because conjunctivitis and uveitis look similar at first glance, you don't know which one it is necessarily right off the hop. So very, very important to once again refer, right? So external hordulum, commonly referred to as a stye, is the infection of the meibomian gland in the base layer of the eyelid. Appears as red, painful, raised pimple on the edge of the eyelid. So a stye is very much like a pimple of the eyelid. Okay, so it is acute, meaning it's happening right now and it's inflamed and it's red and it's sore, and you're going to see lots of these, right? Now, is it something that is necessarily needs treatment? Not always. Sometimes it just works itself out. However, if you do have a patient who presents himself with a sty, you kind of want to do it. Sorry, do it. I mean, refer, because a untreated sty can sometimes get hardened and stay there for a long time, and it's not a pretty sight. So you probably wouldn't want to advise people to not have it treated, just in the event that it gets worse or doesn't resolve, right? Um, Similar, that's similar, but again, an eyelid condition. Blepharitis is the inflammation of the eyelid and includes burnings, itching, swelling. One of the most obvious symptoms is a flaky white skin and discharge. It looks like dandruff on the eyelashes, and the eyelids get real pink and not nice. This is often secondary to other issues like dry eye syndrome or autoimmune disorders. Um, what's a common one I'm trying to think of here? It's escaping me. There's a common skin condition, it'll come back to me, that is associated with blepharitis. It's one of the ones that's pretty easy to distinguish. If the eyelids look like they're in trouble, it's probably blepharitis, and you have to refer that because it's very uncomfortable and it's unmistakable. Eyelid inflammation is no good. Let's move on to something else here. So chalazion. So I probably should have put the chalazion closer to the sty or the external hordulum because they're often mistaken for each other and they're very, very similar. So this is inflammation of a meibomian gland resulting in cyst formation, usually the result of a clogged gland or clogged gland rather than infection. So a chalazion, interestingly, and why it's often misunderstood by people who are just starting off, is that it can have a couple different causes. It could start as a chalazion, basically a gland that gets blocked, never really gets inflamed, um, and basically just creates a hardened mass. That is a chalazion, all right? Or it could be a sty, external hordulum, that is inflamed, it is a cyst, it is like a pimple that doesn't get treated and doesn't resolve itself properly and then forms a hardened mass or a cyst. So a chalazion is less acute, it's a little bit more benign, and sometimes just won't reabsorb into the body and often has to be removed surgically. So again, if there's a lump on the eyelid, it needs to be referred so that the professional, the doctor, can assess it and decide what needs to be done. So just try to understand the difference between a hordulum and a chalazion. One's acute, one's a little bit more chronic. It's been there for a while and it's likely not going away. Now, subconjunctival hemorrhage is something that is often observed post-trauma or even from a really strong sneeze. And it's bleeding between the conjunctiva and the sclera because there's all these little blood capillaries, blood vessels inside the conjunctiva, and sometimes it could burst. It can be, like I said, traumatic, spontaneous, or secondary to systemic illness, like bleeding disorders or hypertension. However, it could also just be from just regular stuff, like I said, sneezing, or sometimes people. One of the most common times that people get these is they wake up with them, and it could be really, really stressful and nerve-wracking for these patients when they wake up and they have a huge blood stain on their eye. For the most part, it's benign and doesn't require treatment. However, it's very difficult to to calm a patient down when they have blood in the eye. So even though most of these probably don't need to be referred, I would suggest you refer it so that, peace of mind. And you don't want to miss anything. It's not your job to diagnose. Therefore, even though you might know what it is, it doesn't mean that you should be, handing out diagnoses. So, you see a blood stain on the eye, it's probably a subconjunctival hemorrhage. However, you refer anyway. And moving on to an entropion, which is a condition in which the eyelid turns inward and the eyelashes rub against the eye. Common in elderly people, also common when people have neurological disorders that affect the eyelid from staying open or, open in the right kind of orientation. The main thing with an entropion is not necessarily the turning in that's the problem, but it's what happens if left untreated, and it could result in a corneal abrasion, corneal scarring, keratitis, and eventually, if that's not treated, loss of vision. think about it. The eyelid is turned in, and you got all these little brushes. You have the eyelashes rubbing against the cornea and the conjunctiva, and if it's doing it over and over again, it's going to cause issues. We looked at images of corneal abrasions and things like that. We know what that looks like, and we know that it can lead to keratitis and it can lead to all sorts of conditions. Well, if you have something rubbing on the cornea all the time, this is a concern. And moving on to basal cell carcinoma, well, this is cancer of the eye. And this is obviously bad news. It's not necessarily just the eye, but the whole area around the eyelid and the adnexa, essentially. And this is going to be something you see much less commonly. However, I did want you to know about it that, unfortunately, most parts of the body can be affected by cancer. So can the eye, so can the adnexa, and it's something that definitely needs to be treated by, the ophthalmologist and an oncologist. And you're obviously not going to be part of this, but you may encounter patients that are going through treatments and still require counseling, not necessarily, medical advice. However, empathy and understanding what they're going through. So, just wanted to touch. So, what's the significance? Well, like I alluded to, you can't know them all, but you should know the common ones. And I think we've done a good job from, between the last few lectures and this one, understanding most of what is going to be coming in through your doors. We've probably missed a few that, you could, because there's rare things that could happen that, we can't necessarily go all of them. However, these are the main ones. And again, I'm going to say it again and again, just know what is normal and what is not normal, and that is a good start, because if you know what normal looks like, you're going to be able to distinguish when it's not, and you'll be able to refer. That's the main key here. You don't need to be able to be a encyclopedia of pathology. You just need to be able to understand what's normal so that you can, again, refer when it's not. And remember, you're the first line of defense, right? And you have to know when to refer. So you're going to end up, imagine, most doctors' offices aren't open Saturdays and Sundays, and you might be working one day, and one of these things comes in and you have to make a decision. And I'm not going to be able to give you, too much insight in these kind of lectures about what you're going to have to do in that moment. And it's going to require a judgment call, and experience does factor in here. Over time, you're going to start to understand, but you're going to have to make a decision as to what you do. Do you send the person to the emergency room? Do you tell them to wait till Monday? Very difficult for me to give you that advice in this particular moment. However, again, if you're inexperienced and you haven't been doing this a long time, it's probably best to be safer than sorry. So you probably should refer. And, over time, you're going to start to understand a little bit better about which things are more urgent than others. But for the most part, it's not your job to decide, right? All right, I think that should do it for this lecture. We've covered a lot of things here. And why don't we move on to the next?